So welcome to everyone who's joined us. I'm Melanie Peters, Development Manager for Wales and Northern Ireland with Glaucoma UK, and our speaker today is Professor Andy McNaught from Gloucestershire Hospitals. And we're going to be covering visual fields. I'm so glad so many of you have chosen to spend your afternoon with us. I'll just spend a few minutes talking about the format of today's talk, the technical side of Zoom, and who Glaucoma UK are. There'll be two short polls launched during the webinar, and these to help us see the difference the sessions are having. And I'm just going to launch the first one now. And I'll leave that up for a couple of minutes. And these help us to see the difference the sessions are making. So if you'd like to ask a question, please wiggle your mouse or touch your screen, and you'll see the Q&A option at the bottom of your screen. If you have questions for me or Andy, type them here. You can ask questions whenever, and we can see these throughout the session. Even if you don't have any questions, keep an eye on the Q&A panel. If you like a particular question, you can click like. And the most popular questions will come to the top of the list, and we'll try to answer them first. The chat button can be used if you're having any technical issues, but please keep your questions to our panelists in the Q&A section. It just makes it easier for us to keep everything in one place. We really want this session to be interactive and cover the topics you're most interested in. So please do ask any questions. The only silly question is the one you wanted to ask, but you never did. We'll activate closed captioning during this talk. If you want to switch them on, click on the button marked CC Live Transcript. This is automatic subtitling, but it does struggle with medical vocabulary. And we've seen trabeculectomy turn to Rebecca said to me, and even trab turn to Trump. So Glaucoma UK is the UK's charity for people with glaucoma. We work in three main areas to prevent glaucoma sight loss. Firstly, we campaign to raise awareness of the disease. We want people to know what glaucoma is and about the importance of getting your eyes tested. The earlier glaucoma is diagnosed, the less likely people are to experience sight loss. Secondly, we provide support and advice to people with glaucoma and those who care for them. We have information leaflets, a helpline, a buddy service, and a patient forum. And we provide training and advice to professionals looking after people with glaucoma, and all our services are free. Finally, we fund research into the diagnosis, treatment, care, and prevention of glaucoma. It's not a huge amount of money, but we often provide initial funding for seed research, and that gets early stage research going. After Andy has finished speaking, we'll have a Q&A session. Please post any questions in the Q&A box, and don't forget to like questions that others have asked. If you're watching this on Facebook, comment on the feed, and your question will be fed into our webinar. So I'm going to hand over now to the speaker, Andy, and don't forget to post your questions in the Q&A session. Thank you ever so much, Andy. Over to you.
Thanks, Melanie. Thanks very much. Thanks very much to Glaucoma UK for asking me to do this. I should say that I've been doing glaucoma for about 30 years. And as the question says, and I've actually taken the question as an invite to talk about all the things that have changed recently and all the things that haven't changed. And really, there's a goodly proportion of the practice of glaucoma care that haven't changed. And that for sure there have been some recent changes, especially in surgery in recent years. So I'll touch on all of that, and I'll touch on visual fields as well, of course, because that was the center of the question. But I've used it as an invite to talk about a whole range of things, really, to cover most of the things that you might be interested in, actually. So, Melanie, can I have my first slide, do you think, please? Great. Yeah, so that's me. I work in Gloucestershire. That's an old print of Cheltenham General Hospital in about 1850 when it was built. It's had a lot of new bits put on since then, but it's a nice building. And that's where the eye department's based. So next one, thanks. So just to say what glaucoma is, well, it's actually not one disease. It's a group of related diseases, and they're defined by the presence of damage to the nerve and the visual field in a characteristic pattern. Most, but not all patients with glaucoma have got high pressure in their eyes, and that's the most important risk factor for optic nerve head and visual field damage, and it's present in most patients, but not all. The other thing about glaucoma that's important is that in most patients with glaucoma, there's no symptoms until there's quite a lot of damage to the vision already, and it sneaks up on patients, and it has to be, it's usually detected by the optician, usually in patients that haven't actually noticed any disturbance in their vision at all. And ideally, the optician will pick up the glaucoma during a routine eye test at an early stage, and so the treatment can be at its most effective, because the treatment can only really promise to try and prevent future damage. It can't restore vision once it's been lost. So we like it to be diagnosed early. Next one, thanks. Next slide. Yeah, that's great. So this is a picture, it's a photograph on the left of somebody's optic nerve head. So that's where the optic nerve comes into the back of the eyeball. So basically, so it's end on. And you can see those red lines, they're all blood vessels coming out of the optic nerve. So that's how the blood vessels get in and out of the eye as well. And this is a picture of somebody with glaucoma, and you can see the optic nerve, it's quite a pale color, and it's also got an enlarged, what we call the cup, is a central depression in the nerve. In a normal person, it's much smaller than that, but as you might imagine, the continual pressure on the optic nerve from the pressure being high inside the eyeball sort of squashes the tissues and makes the cup larger, and that's a characteristic appearance of somebody who's got glaucoma. And on the right is their visual field test, showing dark areas which are in a sort of an arc shape, and that's very typical of the damage that patients with glaucoma get. And it tends to be more in the peripheral vision than the central vision. But if it's allowed to progress, if it's not treated, then it'll eventually involve the central vision, and that's when the patient usually becomes aware of it. Next slide, thanks. And I've put this on. This is an old slide of mine, and it shows what, it gives you some idea of how fast glaucoma can move, or how fast it typically moves. And you'll see the dates on here are really many years ago. And interestingly, about the question, the original question actually for this talk about visual fields, is that the machine that these fields were done on in the 1980s and 90s hasn't changed. The technology hasn't changed since then. It was, and that's to do with the fact there's a number of reasons for that. It's one to do with that it was a great design to start with. There's another reason, which is to do with the fact that you can't easily change the device you measure somebody's vision on halfway through their care. So I've got patients I've looked after in Gloucestershire for almost 25 years. And if we suddenly changed the way they measure their vision, I couldn't use any of the old tests to see if they're getting worse. So changing the way you measure the visual field is quite a big step, and we're not quite ready to do that yet. So yes, the technology is old, but yes, it was a great design all those years ago. Anyway, so this is a series of visual fields over 3 years, and you can see in the bottom right of the visual field, at each of these visual fields, there's an arc-shaped defect that's getting bigger and deeper very slowly over those years, and that's how glaucoma typically behaves. And so the treatment's directed at trying to stop that happening. And this particular patient, obviously, that wasn't fully successful, so they continue to get worse anyway. But it's to give you an idea of the natural history really of the disease. So next one, thanks. So who gets glaucoma? Well, mainly older people, not exclusively, but mainly older. It becomes really quite common in people in their 80s, say more than 10%, but it can affect, it affects typically 1 or 2% of over 40-year-olds, especially people that have got a family history. So if you've got a family history in a first-degree relative, like a parent or a sibling, the risk of getting glaucoma is maybe it goes from maybe 1 or 2% in somebody without a family history to maybe 10 or 15% in somebody who's got a first-degree relative. So it's very inherited disease. We do see younger patients. We see glaucoma in babies sometimes, very rare. Children likewise, and we see it after eye surgery, especially big surgery, extensive surgery, retinal surgery. We see it after eye injuries and in patients who've got uveitis, which is inflammation inside the eye. So there's a number of causes of secondary glaucoma, but most patients have got what we call open angle glaucoma, and most of them develop that when they're older. Next one, thanks. So how do we treat it? Well, as I said, for most patients, not all, but most patients, it's to do with the pressure in the eyeball being literally the pressure inside the eyeball being too high. And the treatment has been shown over many studies that lowering the pressure is the best way to stop the glaucoma getting worse. So we just try and make the pressure, the intraocular pressure, the IOP, lower using whatever means, medical or surgical treatment. Next slide, thanks. And so we sort of knew that, we sort of knew that for many years, but it's only really in recent, probably the last 15, well, certainly 15 years, that there have been a number of randomized controlled trials that have definitely confirmed that making the pressure lower stops glaucoma or slows glaucoma in its progression. And there's there's another condition called OHT, or ocular hypertension, that is a risk factor for developing glaucoma damage. It's much more common ocular hypertension. So that's just basically where the pressure is a bit high and there's no signs of damage. And this study, the ocular hypertension treatment study, OATS study, they treated patients with high pressure and showed that you can halve the risk of the patient getting damage if you treat the high pressure. So it was that was the first trial that showed it was constructive to try and prevent the onset of glaucoma by treating people that have simply got high pressure but haven't got any actual damages yet. So it's pretty solid that lowering the pressure is helpful in glaucoma. Thanks. Next one. Next one. So talk about medical treatments. So most patients with glaucoma will just need medical treatments. That is treatment with eye drops. So how do they work? Well, the eyeball is filled up with water. It's called aqueous humor. It's mainly in the front chamber of the eye because the back of the eye has got more sort of jellified vitreous at the back of the eye. But so the front section of the eye is certainly full of water. And it's created inside the eye continuously. It's made in what's called the ciliary body. So the eye has to have a turnover of water inside it because the eyeball, because it's got lots of transparent structures, the cornea, the lens, that have to let light through so we can see. They don't have blood vessels. If they have blood vessels on them, we wouldn't be able to see properly. So they're transparent, and so they need to get their oxygen and glucose somehow. So the water is being produced all the time with oxygen and glucose in it to supply them with what they need. And of course, if the fluid is being made inside this closed container, which is the eyeball, it needs to get out again. And so it goes out through a thing called the trabeculum, which is like a sort of filter. And it also goes out through the base of the iris, which is another route, which is smaller, called the uveoscleral route. And so given that the eye is making this fluid, this aqueous all the time, and it's draining away all of the time, you can obviously lower the pressure if you need to, if someone's got glaucoma, by reducing either and/or the production of the fluid and/or increasing the drainage of the aqueous fluid from the eye. Those are the two ways that you can make the pressure come down. Next one, thanks. So we still use beta blocker eye drops. They can be very powerful. They've been around for many years. They were invented in the late 1970s and started being used extensively in the 80s. So that's and the commonest would be timolol. That's a commonest beta blocker eye drop. And beta blockers eye drops work by reducing the production of aqueous. So even if the drainage system doesn't work properly, if you reduce the production of aqueous, the pressure will come down. And they work best if they're put in the morning, because most of the aqueous that's made is made during the day. There's a bit less made overnight. They can be really effective, but not everybody responds. But their effect can wear off, or maybe the effect wears off, or maybe the glaucoma gets worse. We're not quite sure. But either way, if you respond to beta blockers, you may not stay on them for life. You may need to be changed on something else. But anyway, they're very useful drops, and some patients do use them for life, and that's all the treatment they ever need. Next one, thanks. So beta blockers, timolol, typically, and of course beta blockers, I'll talk about this later, but beta blockers are used also in combination drops, in combination with other drugs. But any person that's using a drop that has timolol in it, they need to be aware that although they're very effective, they carry some tiny risks. They can, in some patients, they can make asthma worse. It's pretty rare, but they can make asthma significantly worse in some patients in a dangerous way. It's very rare, but it happens. They can also affect your heart. If you've got a very slow heartbeat, if you've got heart block, it can occasionally make the heart slower in a dangerous way. It's very rare, but it's possible. It's good to know it's possible. Definitely, it reduces exercise tolerance. So people that are younger patients that are very active, if they run, for example, go to the gym, they'll find that they perform slightly worse when they're using beta blocker eye drops, because it does affect how the heart responds to exercise. It can't respond quite so avidly to exercise. And patients who have had or have depression, it can aggravate that. So it's not a good choice for somebody who suffers from depression. So those are significant, mostly rare, but significant problems sometimes with beta blocker eye drops. But if we can avoid those side effects, they can be really effective. Next slide, thanks. Other ways to make the pressure come down, what's called carbonic anhydrase inhibitor eye drops. That's another way of reducing the production of fluid, because carbonic anhydrase is an enzyme that helps make aqueous fluid. You can give these drugs either as tablets, systemic, so that's for the whole body, and those tablets are called Diamox or acetazolamide. And we tend to reserve that for people that have got quite troublesome and severe glaucoma. Or you can use it as eye drops, either in the form of dorzolamide, it's called Trusopt, or brinzolamide, which is called Azopt. The Diamox, the tablets are really effective, but they've got loads of side effects. They're not so pleasant to take long term, especially. But the eye drops, interestingly, aren't terribly effective. So they're not our first line choice because they're not particularly effective, but they are very free of side effects. The drops, the tablets are the ones that have the main side effects. Next one, thanks. Other ways to lower the pressure, a drop called brimonidine, also called Alphagan. It's quite effective. It has a major problem that it tends to cause the eyes to get sore and red. And so we don't use it as our first choice drop for that reason. Next slide, thanks. Aqueous. So as I said, there are different ways. There are two ways to make the pressure come down in the eye. One is to reduce the production, just talked about those. The other way is to improve drainage from the eye. That's been around for many years. One of the first drops we ever had for treating glaucoma improves drainage, and it's called pilocarpine. And I've still got patients that I give pilocarpine to. Even now, it's still a useful drug. It has lots of side effects, so it's not ideal, but it's still useful in some patients. Interestingly, it's made from a flower that grows in the Amazon jungle. It's not a synthetic, it's farmed. So it can be difficult to get hold of sometimes because there's not a big market for it these days. Pilocarpine. Next one, thanks. The big drops, the most important drops we have now, and they affect the drainage of aqueous, are prostaglandins. Latanoprost is the most important of all because it's the best, probably. It was invented, it appeared in 1996, and it really transformed glaucoma practice then. It's really effective. It's really free of side effects. And it's very, very safe. It doesn't have the systemic side effects that beta blockers have. Other drops that work in the same way as latanoprost, that's Xalatan. So that's bimatoprost, that's called Lumigan, that's trade name. Tafloprost, Saflotan, Travoprost, Travatan. They're all basically the same, and they all lower the pressure by increasing drainage. They're all actually more effective. Not only are they safer, but they're more effective than timolol or brimonidine, and you only need to use them once a day. Very few side effects. Next slide, thanks. This slide's quite interesting. This shows you quite how dramatic the effect of latanoprost introduction was in 1996, 97. So that graph shows the frequency of trabeculectomies done in the UK, and you can see that after this new radical new treatment was introduced, the number of trabeculectomies, that's glaucoma surgeries, done rapidly fell off. I mean, it's increased a lot since, but it went down for many years simply because of this new drug being introduced, latanoprost, because it's very effective. Next one, thanks. Yeah, they do have some side effects, but they're really quite relatively minor. They do sometimes make the eyes a bit pink looking, quite commonly, really, but not in a tiresome way. They very commonly make the eyelashes grow longer. Sometimes that's a bit of a problem. Some patients quite like it, other patients don't. They can change the color of the iris. So if you've got blue eyes, it tends not to have any effect. If you've got dark brown eyes, it won't have any effect because they're very brown already. But the tendency is to make the eyes a bit more brown. So if you've got green eyes or mixed color like hazel mixed with gray, say, it'll often make the brown parts look more brown. So you get increasingly brown eyes. Of course, if you're using it in both eyes, it's symmetrical, so it doesn't really notice. But that's why I don't use it just in one eye, because you tend to get this asymmetric appearance of not just the lashes, but also the color of the iris if they've got a mixed color to their iris. I mean, there's a very rare reported side effect that can cause trouble with the retina, with the macula, with latanoprost, but it's excessively rare. I've only seen it once or twice, I think. So so basically they're very harmless drops and very effective. Next one, thanks. Yeah, so timolol, the beta blocker I mentioned, and these prostaglandins appear in combination drops called variously Ganforth, Duotrav. Timolol appears with the carbonic anhydrase drugs Trusopt and Azopt in Cosopt and Azaga, and timolol appears with brimonidine in Combigan as well. And there's yet another combination, which is brimonidine and brinzolamide together, which is very much a last resort because it's got a very strong tendency to make the eyes red and sore. These drugs are quite good for patients who've got pressure that's not well controlled with just one drop, and they probably improve the compliance with the treatment because it's just one single bottle to use, and you get two different drugs within that single bottle. So they have their strengths actually. So next slide, thanks. Preservative-free. In recent years, we've had preservative-free drops that they often come in that little vials. You tear the top off and use them. Use a new one each day, and they are definitely kinder to the eyes. So if somebody's reacting to the preservatives in conventional dropper bottle, they can use these preservative-free ones, and they're more comfortable with those. So that's been a step forward, and that's a recent development. Next one, thanks. Okay, surgical treatment. That's a picture of somebody who's just had a trabeculectomy. You can just about see the stitches underneath the conjunctiva there. On to the next one, thanks. Yeah, before I talk about treatments for open-angle glaucoma. So open-angle glaucoma is the most common type of glaucoma and affects about 80% of people with glaucoma that we see in the clinic. Minority type of glaucoma that affects about 10% of patients in the clinic is called angle closure glaucoma, or ACG. And angle closure glaucoma, although it is to do with the pressure, the cause of the pressure being high is less to do with the drainage system slowly stopping working, which is what happens with open angle glaucoma. It's more to do with they're people with relatively small eyes, and so the contents of the eyes, the eyeball is the stuff that's inside the eyeball, the lens and the iris, everything else is all rather cramped together, and because it's cramped together, there's not enough room for the fluid to easily get out of the eye. So it sort of blocks the drainage system. The iris blocks the drainage system because there's just simply not enough room for the fluid to get out. So there's a diagram there with a sort of left-hand side of the eye, which shows the normal arrangement and the circulation of aqueous going from behind the iris, from the ciliary body, going through the pupil and then out through the drainage system, the trabecular meshwork. And then on the right side of the diagram, it shows you the situation is somebody who's got angle closure glaucoma, whose eyeball's a good deal smaller, and you can see everything's all jammed together and there's not enough room for the fluid to get to the trabeculum. So there's a strong tendency for the pressure to shoot up, sometimes suddenly. So you can get acute glaucoma, which is a dramatic condition. And you can see at the bottom there how we often treat it, which is to make a little hole in the iris called an iridotomy, which allows a sort of a shortcut for the fluid to get through to the trabeculum, because the iris would otherwise be in the way. Next slide, thanks. So yeah, so the treatment of angle closure glaucoma is mostly surgical. It involves laser treatment to make a hole in the iris. And there's been another recent development, a UK-based randomized controlled trial called EAGLE, which shows that just doing a conventional cataract operation, if you've got angle closure glaucoma, is very beneficial to the progress of the glaucoma. And it's simply because it makes space inside this otherwise crowded eyeball to help the fluid drain more easily, so making the pressure come down, so reducing the risk of the glaucoma getting worse or behaving badly. And why is that? Well, that's because the natural lens is much thicker than the implant lens. So when you have a cataract operation, the implant lens is a third or a quarter as thick as your natural lens. So that literally makes loads more space inside the eyeball to allow the fluid to drain out more easily. Next one, thanks. So on this theme of laser, going back to open angle glaucoma, so that's the common type of glaucoma where the problem is more the failure of the drainage system to work properly. We can treat the drainage system directly with the laser, and that seems to help it work better. We used to treat it with a thing called the argon laser, and there's a more modern version of that in recent years called selective laser, or SLT, and that's a type of YAG laser. So basically, either or both of these treatments treat the glaucoma by making a little burn in the trabeculum, and that somehow seems to make the trabeculum drain the fluid better. So next slide. It's very safe. It works quite well. It doesn't always work, but it works quite well. Obviously, it's much better compliance because the patient doesn't have to put drops in every day. Once the laser's done, it can work for many years, actually. The two different types of laser don't seem to work very differently in terms of their efficiency. The more modern one, the SLT, is said to be more repeatable because it uses less laser energy, so it's less destructive. So that's probably the advantage of the more modern SLT type treatment. Next slide, thanks. Disadvantages, well, it doesn't always work. It works about 70% of the time, and it works best, strangely, it works, the higher the pressure before the treatment, laser treatment, the better the laser treatment works. It doesn't work very well if the person's pressure is not terribly high. The other problem with it is that it doesn't last that long. It typically lasts for a year or two and then it wears off. Not always, but often. So it's not often a definitive treatment for the glaucoma. It's more often a sort of a temporary measure. And there is a tiny risk in some patients of the pressure shooting up dramatically straight after the laser treatment. So that's a real risk, but it's very rare actually. Next one, thanks. And this is a plot from a recent, again, UK-based randomized controlled trial called LIGHT, which was all about the SLT laser. And it showed that, again, as I said, the higher the initial pressure in the eye, the better the pressure lowering from the laser treatment. Next slide, thanks. So going on to surgery that doesn't involve the laser, that does involve going to the operating theatre and having microsurgery under the microscope. And so still the most common glaucoma surgical treatment is called trabeculectomy. It's been around since the 1980s, but it's a much better operation now because the technique's been improved with the success has been improved with the use of mitomycin C, which is an anti-cancer drug. But we dab it on the eye during the operation, and it reduces the risk of failure, because failures, if it occurs, is usually due to scarring, and it reduces the risk of scarring afterwards. We also use a suturing or stitching technique using very fine sutures that have increased the safety of the operation and the flexibility of the operation. It's not a terribly easy operation to do. It needs lots of practice and years of practice, and so there is a bit of variation between surgeons, both in the safety and efficacy. But there's some recent, again, research from the UK looking at surgeons that use the more modern techniques, the technique that I use, and my colleagues that trained around the same time as I did, and since showing much better results than the previous publications. Next slide, thanks. And this is it. It was called Trabeculectomy in the 21st Century. And that's a UK-based study showing that trabeculectomy is much more effective and safer than some of the earlier reports from before then. So next slide, thanks. So it was a UK-based study. We had to all provide 50 consecutive cases of trabeculectomies, and we had to show the results from the surgery at 2 years of follow-up. Next one slide. And you can see this graph here showing the pre-op pressure was typically around 25 millimeters of mercury, somewhere between 20 and 30. And the post-op pressure out to, in fact, the graph shows out to 3 years, is really very good. It's like in the round pressure of around 11 or 12, low teens. And so it's really quite an effective operation. Next slide. Complication rate with this modern technique in this particular study compared with some older data, the complication rate is very low, very safe operation. The only thing to say really is it does have a strong tendency to make cataracts come on a bit sooner than they would have otherwise come on. But cataracts, of course, can be easily dealt with. Next slide, thanks. And it's very effective. So the median sort of average pressure drop from the operation is about 50%. So it's big. Next one, thanks. So talking about some other ways of doing surgery to lower the pressure, there's tube surgery. So that's a less commonly done operation, and it tends to be reserved for patients with failed trabeculectomy operations or severe secondary glaucomas or children with glaucoma. It's effective, but you don't get such low pressures as you get with a trabeculectomy. You often you need to use drops as well, and there's some risk involved because you're basically putting a bit of plastic inside the eye, a plastic tube, and that's not always very good for some other parts of the eye, the cornea, for example. So there are long-term risks from having a plastic drainage tube put in your eye, but usually they're reserved, as I say, for the more severely affected patients that would otherwise lose their vision from the glaucoma if it wasn't treated properly. Next slide, thanks. And really, this is really quite recent developments. This is so-called minimally invasive glaucoma surgery, or MIGS. So the concept there is to make the pressure lower using surgery, but with less risk than either trabeculectomy or tube surgery. So that was the sort of starting hypothesis. And there's a range of different ways of doing this. There's ways of operating, if you like, on the inside of the trabecular meshwork to try and improve the drainage through that filter, that trabecular meshwork. And there's been some other devices that you put into a part of the eye called the suprachoroidal space, which I'll talk about. And there's also some other devices, one's called Zen and one's called Preservative. They're implants that work very like a trabeculectomy, but basically putting a tube in that drains fluid underneath the conjunctiva like a trabeculectomy does, and you can end up with lower pressures that way. Next one, please. So talking about trabecular surgery, so this is surgery done on the inside of the eye, from the inside out, if you like, of the trabecular meshwork, which is not working properly in open-angle glaucoma. There's the trabectome, which is like, I suppose it's like a little cutter or like a little hoover on a microscopic scale that hoovers out all the debris and silting up of the trabeculum to help fluid drain out more easily. So that sounds attractive, doesn't it? But in fact, sadly, it doesn't work that well. That's the main problem with this operation. It's very safe. Sometimes it causes a little bit of bleeding that clears by itself, but it lowers the pressure really by a few points only. There's some report of a study there showing it lowers the pressure from, in this case, low 20s to high teens. And the effective treatment doesn't last very long. And on average, the patient reduced the number of drops they're using basically by one. So it wasn't a hugely dramatic operation. So compare that with the trabeculectomy that reduces the pressure by 50%. It's really quite small compared with that. Next one, thanks. There's the eye stent. That's another very safe operation. It involves putting a little metal tube into the trabeculum from the inside again. There's not very much long-term data. Most of these studies report using the eye stent combined with a cataract operation. It's worth knowing a cataract operation, if you did a cataract operation alone, it makes the pressure go down. So the additional lowering caused by this little metal tube is debatable. And in fact, the early studies used one of these. Now the advice is to use two, because the pressure lowering from one was so slight. It's somewhat better if you use two of these instead. Next slide, thanks. And there's a report of a citation of a research there showing that, for example, at 1 year, 72% of the eye stent plus cataract operations had pressure less than 21, compared with just 50% of the cataract alone. So that was a significant difference. But the amount of lowering of the pressure well, it was, if you look at, if you do a cataract operation alone, you get somewhere around a 6% lowering of the pressure. If you do a cataract operation with an eye stent, you get about 8% at a year. So it's, again, it's not a big drop in the intraocular pressure, but it is safe. Next one, thanks. Hydrus, very similar to the eye stent. It's bigger. There's not very much long-term data. It's not a lot more effective than the eye stent. Next one, thanks. So there has been some research, again, in patients with having cataract surgery simultaneously, and it produced, so if you look there, it's the pressure at 2 years was about 17 millimeters of mercury in those that had the hydrus and the cataract, versus about 19 in those that had the cataract operation alone. So again, it's only a 2 millimeter of mercury drop, which is quite small, but it's safe. Next slide, thanks. CyPass, this was a different idea. This was a metal tube that you're supposed to put into, basically into the root of the iris, into the space behind the iris called the suprachoroidal space. And initially it looked as if it was going to be really effective. In fact, my colleague and I started training to start doing this operation in Gloucestershire. However, in the week we were due to start using it, it was actually withdrawn because there was some concern about how safe it was in the long term. Because again, all of these little tubes, little plastic tubes, metal tubes that you put in the eye, they all carry a small risk of disturbing the cells on the back of the cornea in the long term. And this one seemed, even in quite early, a year or two after implantation, to reduce the number of cells on the cornea and to present a threat in the long term. So it was withdrawn. So we never used it. We ended up using it in the end. That was abandoned. So the CyPass is no longer used. Next one, thanks. Zen, that's still quite popular. That's a little plastic tube that you put into the eye, and it works in a similar way to a trabeculectomy. It was said to be lower risk than a trabeculectomy originally, but there's quite strong evidence that it carries the same risks as a trabeculectomy. It's no safer. It might not be quite as effective, so it's becoming a bit less popular now. Watch this space, but there was a period where a lot of Zen tubes were put in. Next slide, thanks. And I should say there's another newer device called the Preservative, which is a very similar principle, and again works in a very similar way to trabeculectomy. So I've tried to summarize these pros and cons here in this table. At the top there, it says, top left, it says medical treatment. So medical treatment, that's drops, is a really common treatment for glaucoma. It can be really efficient treatment. It's really cost effective because latanoprost is now off patent. It's a generic drug. It's very, very cheap. It's one of the most cost effective treatments the NHS provides because it deals with 80% of the glaucoma that's out there, and it's very cheap and very effective. Laser treatment, similarly, is very safe. It's less popular than drops. It's very acceptable to patients, but it doesn't always last for more than a couple of 3 years. So that's a significant disadvantage of laser treatment. These new surgical treatments, they're becoming slowly more popular. They are safe, mostly, CyPass with the exception, mostly safe. Question marks about how effective they are, and we'll need to wait for a lot more studies, like with years of follow-up to see how well they compare with well-trusted treatments like trabeculectomies and tube operations. But they're certainly carving a space for themselves. But there remain questions about how effective they are and how safe they are in the long run. Trabeculectomy has been around for years and years. There's lots of studies. We do know a lot about it. There are some risks involved for sure. Modern technique is much safer. It's very when it works, it's very cost effective because I've got patients that I operated on when I started here in 1999. What's that? 23 years ago, and their trabeculectomies are still working and protecting them from glaucoma damage. So it can be a wonderful treatment and can last forever. Basically, we do the operation in children. It can last for their lifetime, but it does involve a little bit of risk, and it is quite a performance to get the thing done. It's not, it's quite a big operation, but it can be really effective. Next slide, thanks. So if you asked UK consultants like me how they would choose to treat people with glaucoma, this study is really interesting, but it's quite old now. I think that the choices might have changed a little since then. But anyway, their first choice medical treatment of the respondents was latanoprost, because it's the best prostaglandin, it's the cheapest. And timolol was a choice in a minority, less. And timolol is an excellent treatment as well, a beta blocker. No respondents chose laser as the first choice, but since the light study, which was published 2 years ago, I think laser has become a lot more popular because it's been shown to work, even though, as I say, it doesn't last forever usually. None of the respondents chose surgery as the first choice for mild or moderate glaucoma. Trabeculectomy was the first line treatment, but again, things might have changed with the modern MIGS treatments. But trabeculectomy probably in this country is still the most popular. Next one, thanks. So conclusions, what do? I start with a prostaglandin or a laser in ocular hypertension, try and lower the pressure by about 30%. If that doesn't work, I'll try using one of the other prostaglandins. They're sometimes more effective. Add a beta blocker if they're allowed, if the patient's well enough to have beta blocker, or one of the other drops. Preservative free if the eye is uncomfortable with the drops with the preservative. And surgery, usually a trabeculectomy if the pressure is still too high, and especially if the visual field is getting worse. Laser in some patients with not very severe glaucoma. And the place of the new MIGS surgeries, I'm uncertain. I think I would prefer to have more data, but I expect in the future we will be using one or other of those a bit more. Next one, thanks. Yeah, so most glaucoma patients are treated with these highly effective eye drops, very cost effective and efficient. Laser is becoming more popular. Trabeculectomy is still popular, but possibly less because of the rise of the MIGS operations. But there's a risk they might undertreat more severe glaucomas if they're used instead of trabeculectomies because they don't work as well as trabeculectomies. Next, thanks. Next slide. Right, so finally, coming back to the visual fields, why are we still using visual fields? Well, whilst granted they are sometimes unpopular with patients, I should say I did my PhD on visual fields. I've done loads of visual fields myself and I understand why they're unpopular. But they're still the best way to find out if the glaucoma is stable, whether the medical or surgical treatment is working. If the visual field is not getting worse, then whatever treatment the patient's on, assuming that it's put up with, is just fine. There's a lot of interest in retinal scanning, OCTs, new ways of imaging, but it's not a direct replacement for visual fields because it doesn't measure the thing that's most important, which is what the patient can see. So that's it. Thanks very much.
Okay. Oh, thanks, Andy. Thank you ever so much. Yeah, we've got quite a few questions, and we're going to crack on. We've got questions about visual field tests. So the first one is, how often should a visual field test be done?
It depends. Okay, so in somebody who's got, general rule of thumb, if somebody's got visual field damage, then that in my book, they're at higher risk of future trouble with their vision, and I would do their visual fields more often. So, for example, depending on how concerned I was about the pressure as well, they might have their visual fields done 2 or 3 times a year. If they've got a normal visual field and their pressure is under control, so they've got ocular hypertension, say, then they don't need a visual field that often, maybe once a year. So it depends.
Right. Okay. And we have another question here. Can you tell us the difference between the visual field test the DVLA would use compared to the one done in the hospital?
Yeah, absolutely. So the purpose of the visual field test in the hospital is to find out if each eye is doing okay with the treatment that it has. So we measure each eye individually with a very sensitive and prolonged, many would say tiresome test, to make sure that we've measured the quality of the visual field, the quality of the vision in either eye really carefully. So it's called a threshold visual field test. Whereas the DVLA test is different because the task is different. The DVLA wants to know what's the visual field like with both eyes open, and is it good enough to drive? And so the test is done, their test is done with both eyes open. It's not as detailed, and it's a simple question, which is the field wide enough and tall enough to satisfy their requirements? And of course, that DVLA field test would be no good really for measuring whether the glaucoma was getting worse or not, because it's not detailed enough for that.
So it really is basically to see if you're safe to drive.
Yeah, that's all it is. So it's often done on the same machine using a different program, but it is in fact for a different purpose.
Okay, thank you. And somebody's saying, is it possible to learn and get better at doing a visual field test?
Oh yeah, definitely. The visual field test is hard. It's a performance. So unlike scanning the retina with a scanner, like having an image taken, that's an objective test. You know, the person's got, if you're imaging me, I've got no influence on what the result is you'll get. It's like doing a blood test, you know, it's going to be what it is. Whereas a visual field test, it's somebody on the end of a buzzer and they're performing. So if they're sleepy that day or if they're anxious that day, you'll get a different result. And definitely if they're not familiar with the test, they'll usually produce an impaired performance compared with maybe doing the next or the third time they do it. And so I'm well aware of that, and so I'll never make a decision based on one field test, and I'll definitely never make a decision on their first visual field test. I want to see what they do when they've had a bit of practice with it.
Okay, so leading on from that, how subjective is a visual field test, and can it mask progression?
It's wholly subjective. It's completely subjective. It's absolutely a performance. And so, for example, people who have got dementia, you know, moderate severe dementia, cannot do a visual field test because they cannot follow what's required of the test. And so of somebody who's very sleepy, or somebody who's extremely anxious about the test, they often can't perform properly. Some people just can't do visual field tests. Somebody who's got you know, a very droopy upper eyelids, you know, will produce a visual field that's consistent with that. You know, there are all sorts of factors in there that affect the result that you get, and a lot of them are not to do with the eye; they're to do with the person's brain or their performance or their general state. So,
if you perform badly in a visual field test, how quick will it be that you can repeat it? That you can do another one? Can you have another go?
Yeah, we do that sometimes. I mean, it's tiring. It's tiring to do one visual field test, so it's even more tiring to do two. But we do that sometimes. I mean, the commonest scenario actually is that I'll see somebody who's got glaucoma and is using some treatment, drops, let's say, and then they'll come along, have a field test, and it looks a bit worse than before. Okay, and then I'll think to myself, well, I wonder if that's the glaucoma getting worse, or I wonder if it's because they had a bad day because they were up all night or something. And so I'll say, well, let's just, and let's say also the pressure is not perfectly controlled. It's a bit borderline. So I'm a bit suspicious it's a real change. I'll get them back quite quickly within a few weeks or a month, well, 6 weeks, say, something like that, and just do it again. And if we get the same result the second time, then I'm starting to think that it might be real. But half the time it'll be better, and then, you know, no problem.
Okay, and are we likely to see any improvement in the testing and therefore making the patient experience better?
Yes, we are likely eventually, I think. I mean, there's lots of research going on into doing, for example, visual field tests on iPads and computers, that sort of thing. So you don't have to put your head in that bowl, and there's even visual. So a colleague of mine, Dave Crabb, who I did my thesis with, my PhD, we worked closely together. Then he's done some wonderful work on visual fields. For example, he's done some work on measuring people's visual fields indirectly by getting them to just watch a video. So when you get somebody to watch a video, you can their eye movements move around the screen depending on what they're picking up in their visual field, and you can basically calibrate that. Knowing how a normal person responds to the same video, you can make assumptions about how damaged the visual field is just by tracking their eyes whilst they're watching a video. So there are there are people doing research to try and make it a better test. But I think that the fact is, though, it's always probably going to be a challenging test, in the same way that measuring the performance of somebody's arm or their leg, when you've done a joint replacement, the physio is going to try and push you to see what you can do. And we always try measuring the visual field, to push the patient to see what they can do, because we want to get as accurate an estimate of what their vision is as possible. It's no good making the test too easy, because then if you make the test really easy and really quick, then the risk is that you wouldn't measure the vision fully, and they might be losing vision that the test hasn't detected because it's not sensitive enough.
Yeah. There was one person who said they had to have the head held while they were having the visual field test done. They found that extremely stressful. How could we improve that?
I mean, it's a fact that some people find visual fields difficult to do. If the person doing the visual field test can't keep their head on the chin rest and the head rest, and that is constantly moving away, then they won't get a good visual field test result. Now, I mean, one of the ways that the practitioner might react to that is to say, well, maybe you can't do visual field tests. But I think in this case, probably the person doing the test took a more robust attitude and thought that they would hold their head in place. But I mean, I don't know whether I would support that really. But I mean, it's a dilemma, isn't it? Because in the end, all they're trying to do is make a measurement of their vision. And if the person finds it difficult, well, they find it difficult. But then if we don't do a visual field test, we're not going to be able to treat the disease so well. So, it's a dilemma, really.
It is. Moving on, there's been some work in Germany using electrical stimulation, which has been thought to improve vision. Have you got any thoughts on that?
Yeah. Well, I have been involved in this actually peripherally in the past, research-wise. It's very interesting. I mean, it's an established science. It sounds a bit fanciful, but it's an established science in the regeneration of nerves elsewhere in the body using electrical stimulus, and people have tried that with the optic nerve as well.
Would this be specifically for glaucoma or any type of sight loss?
I don't think it would ever be specific for glaucoma. I do know that it's been tried in lots of different types of optic nerve disease. I know that the results so far are quite small. I mean, the effect of this electrical current is quite modest, so it's not like a panacea, but it is interesting. I mean, but by the way, there's lots of research going on right now into, are aspects of the damage from glaucoma reversible in some way. So there's been some really good work by a chap called Johnny Croston, who used to be based, he's British, but he's now in Singapore actually. But he's doing research. He's done some research with mice and rats, and basically shown that different things basically the visual loss with glaucoma is to some extent reversible, and there are very simple maneuvers that he's been with these experimental animals to try and improve the reversibility of visual field loss with glaucoma. And even in my practice, if you treat patients with very severe glaucoma and lower the pressure really dramatically using, for example, a trabeculectomy, so you've got somebody who had a pressure of 50 and it goes down to 10 with a trabeculectomy, it's very common for their vision to improve somewhat, not back to normal, but somewhat. So there is some reversibility, and there is a lot of research and interest in this. There's a new trial starting in the UK that's all to do with that, using novel treatments to do with the mitochondria. Those are the little power plants in the cells that might hold out promise of that sort of thing.
Okay, and moving on, how far away from contact lenses that measure intraocular pressure and deliver drugs effectively do you think we're anywhere near that?
Again, that's been done in last 15 years. That's been done by lots of different groups. Absolutely, there are contact lenses you can wear that measure the pressure. And so they're quite a big contact lens, and then you have to wear like a kit, sort of like a chest strap with all the computers and things to record the measurements of the pressure. I guess you might think that that would be really useful, that it's really useful to measure the pressure in real time all day long and all night. In practice, it's not. It's certainly not worth the risks of wearing contact lens all the time, because in the end, the most important thing in glaucoma is not what the pressure is, it's what the visual field is doing. So that, again, coming back to the visual field, that's a really important measurement, because so I've got patients who have got quite a high pressure and never seem to get any damage from glaucoma. Their pressure's in the high 20s, let's say, and I've looked after them for over 20 years and they've not developed glaucoma. I've got other patients who have got a pressure at worst of 15 and lose vision fast from glaucoma. So in a moment you can see there that the absolute level of the pressure is not the most important thing. It's the behavior of the vision. If the vision's going off, you've got to make the pressure lower, regardless of what the pressure was to start with. So measuring the pressure literally all the time using a contact lens or some device, superficially it sounds attractive, but in practice it's not the main point. The main point is different. The main point is the visual field, actually.
Okay. So on to our final question. Is glaucoma linked to inflammatory conditions?
Glaucoma is linked to, yeah, absolutely. So there are conditions that affect the joints and the skin. Conditions like ankylosing spondylitis or psoriasis that can cause iritis, inflammation inside the eyeball, and it's not at all uncommon that those patients would then get glaucoma as a secondary glaucoma. So there's a whole range of inflammatory bowel disease, sometimes, rarely, that can cause iritis or uveitis, inflammation in the eye, and that can lead on to glaucoma.
Thank you. I'm just moving swiftly on. So thank you so much for joining the webinar. Thank you so much, Andy. Thank you for answering all those questions. We hope you found it useful. We've got the details here for our contacting our helpline. If we haven't been able to answer your question today, our helpline staff will be more than happy to help, or contact them with any other questions you may have about glaucoma. I'm now going to launch our second poll. And that will pop up now, and that will be there for a couple of minutes. So if you could answer that, would be fantastic. Thanks again to our speaker, Andy McNaught, and my colleague Jo for her support. Please consider completing the survey, which will launch when the webinar ends. We want these sessions to be great, so the more feedback we receive, the better sessions we can provide. We hope you found the webinar useful. The details for contacting our helpline, I'll read them out to you. 01233 648 170 or email helpline@glaucoma.uk. Our next talk coming up is the 31st of May at 7 o'clock with Philippa and the helpline staff, and they'll be covering frequently asked questions about glaucoma. We've also got sessions planned on virtual clinics and community monitoring and living well with early onset glaucoma. Please consider completing the survey. That will launch as soon as the webinar ends, and I hope you have a lovely afternoon. Thank you to Andy again. Thank you so much for joining us. Goodbye.